Welcome, everyone. Thank you for joining us all today. And welcome to part one of our ATS Thoracic Oncology Assembly Abstract Scholarship Winner Presentations webinar series. I'm Roger Kim, the chair of the ATS 2A Early Career Professionals Working Group, an assistant professor of medicine at the University of Pennsylvania. And I'm joined by Tejaswi, Nadig, my co-chair and assistant professor of medicine at the Medical University of South Carolina. We'll be moderating today's discussion. Before we get started, just wanted to remind everyone briefly that this is a live event that will be recorded and uploaded to our Assembly website afterward. If you do have any questions throughout the webinar, please place them in the chat, and we'll try to address as many as we can during our time together. As a reminder, the views expressed during the webinar are those of the speakers alone and not necessarily endorsed by the ATS. With that being said, I'm very excited to introduce our ATS 2024 Thoracic Oncology Assembly Award winners who will be sharing their work today. First, we have Cosmo Fowler from Emory University. And then we are also joined by Peter Nauka from University of Pittsburgh and Vidhya Aroumougame from the Medical University of South Carolina. Welcome, all of you. Each award winner will be given about 12 minutes to present their work, which will be followed by about 5 to 7 minutes for discussions and questions. And as a reminder, we have part two of our webinar series featuring abstract award winners later this week on Thursday at 3 p.m. Eastern Time. And we hope many of you will be able to join us for those award-winning presentations as well. With that being said, take it away, Cosmo.
Absolutely. Thank you so much for that introduction, Dr. Kim, and for having me here at this lovely event. I'm going to share my screen and enter the presentation. Please let me know if anything goes haywire, but I think we should be good. I'll be presenting something I titled The First 8 Years, Cardiovascular Immune-Related Adverse Events in Checkpoint Inhibitor Recipients with Metastatic Lung Cancer. So this was a sort of survey of immune checkpoint inhibitor toxicities of a certain kind in patients with metastatic lung cancer using a very large data set that I conducted together with my colleagues, co-fellows at Memorial Sloan Kettering, and a couple of other colleagues at other institutions under the supervision of Dr. Stephen Pastores at the same institution. And I'd like to thank the ATS Thoracic Oncology Assembly for their support of this work as well. No financial relationships to disclose yet, though I'm very hopeful any day now. So I'm going to start, and I won't spend too much time on this, talking about checkpoint inhibitors and their toxicities. Checkpoint inhibitors have completely revolutionized the treatment of solid malignancies. Immunotherapy as a whole has changed the landscape of cancer therapy, as we all know. For the last 8-9 years, checkpoint inhibitors have been a growing mainstay of management in the treatment of lung cancer, particularly. And I'm going to be looking at the cardiovascular toxicities that may be associated with PD-1, PD-L1 targeting immune checkpoint inhibitors. So to spend just a moment on the immune-related adverse event, or the IRAE as it is known in the literature, the immune checkpoint inhibitor acts by knocking out inhibitor molecules on T cells, leading to their upregulation, leading to the upregulation of pro-inflammatory cytokines and B cell mediated autoantibody damage, aimed at, or at least with the therapeutic intent of controlling the spread of malignancy and eradicating it where the appropriate targets are expressed. Now, this has as a
Cosmo,
caveat.
I'm so sorry to interrupt again. I don't think your slides are advancing. If you are advancing, now we can see it.
Well, perhaps if I were to just do a kind of maximize screen.
Yeah, that looks great. Yes, and now we're seeing slide
That's
Yep, now we can see it. Yep.
So this is my slide before. Thank you so much for letting me know that. This is
Sure. Sorry for interrupting.
no. I'm so glad that you did. It would have been quite embarrassing to get through the entire thing, only to have not actually conveyed any of the slides. So this was the timeline taken from publication by Catalano et al. In 2022. And this is the sort of pathophys slide. And as I was saying, these ICI therapies have, as in all forms of immunotherapy, the downside of potentiating immune-mediated damage to off-target sites. In the case of checkpoint inhibitors, we're looking at sort of an acquired autoimmune syndrome, most dramatically perhaps in pneumotoxicity or colitis or encephalitis. But in what is perhaps an understudied subgroup of excess events, additionally cardiovascular adverse events such as myocardial infarction, stroke, and what particularly interested me in this sort of survey, the venous thromboembolic diseases of DVT and pulmonary embolism. So without further ado, we employed the Trinetics data set, which is a very large federated network of anonymized electronic health record, scraped and aggregated information from across the United States. At the time of our query, we were looking at 100 million patient records in total from across all 50 states, incorporating mortality information, laboratory markers, a select number of oncological markers, billing claims, and electronic health record information, some of which obtained through natural language processing of the participating sites. So it would take the form of all patients with an interaction with a given healthcare system would be sort of handed over to the federated network in an anonymized fashion in a way that allows the formulation of specific research questions, queries, and finding associations with therapies and diseases. So we selected a subset of patients from among this very large registry, namely those with an ICD-10-CM diagnosis of lung cancer. And then we drilled down into those that had crossover with a sort of new, at the time new, cohort of metastatic disease labeled patients. And so essentially we're looking at patients with metastatic lung cancer. At the time, the cohort was quite small. It sort of ballooned since then, but I'm presenting on the data that I had at my disposal when we submitted this to ATS. And so between October of 2015 and October of 2022, we had roughly 2,000 patients who met those criteria and received an immune checkpoint inhibitor within 1 year of diagnosis of metastatic lung cancer. And these were Pembro and Nivo primarily, but also atezolizumab and durvalumab. And then we sort of compared them against metastatic lung cancer patients who received no checkpoint inhibitors at any point in time. So looking at a sort of a 2,000 versus 5,500 split. And we queried for the cardiovascular outcomes I alluded to earlier, DVT-PE, as well as myocardial infarction, CVA, and additionally, because it is of interest in the sort of cardiovascular domain in checkpoint inhibitors, myocarditis. And in the gross analysis, what the slide that I'm presenting now is sort of the gross unadjusted analysis. There were excess counts of myocardial infarction, deep venous thrombosis, and PE using ICD-10-CM diagnostic qualifications, as well as myocarditis, all of which were significant. Odds ratios hovering in the sort of 1.5 region, whereas there was no significant difference in stroke or cardiovascular accident incidence, with slightly higher sort of incidence among the ICI group, but not statistically significantly so. Subsequent to that, we conducted one-to-one propensity score matching utilizing demographic data and comorbidity data to look at similar subcohorts of patients who had metastatic lung cancer, as defined earlier in the time frame that we discussed, who received ICIs or did not. And this was looking at age at index, sex, race, and then I think 15 different comorbidities sort of make sure we were looking at people with similar disease burdens from a non-cancer perspective, such as hypertension, heart failure, atrial fibrillation, other things that might have some impact on the outcomes of interest. And we sort of balanced all the patients using in-platform propensity score matching and generated similar like subcohorts. And in these similar like subcohorts of propensity score matched patients, we saw there was still an excess DVT and PE burden in the ICI recipient subgroup, and of course myocarditis. The PE excess was 3% more, leading to an odds ratio of 1.3, with a CI of 1.1 to 1.6, whereas there was no difference in either stroke or myocardial infarction looking at these sort of propensity score matched subgroupings. Then we were interested in looking at these same outcomes in recipients of PD-1 and or versus PD-L1 targeting immune checkpoint inhibitors. So those would be pembrolizumab and nivolumab on one hand and durvalumab atezolizumab on the other. And because we are not restricting ourselves to the M1 subcohort, or rather the metastatic disease, defined metastatic disease label, we had sort of higher or rather larger groupings of each therapeutic group. We saw excess stroke, DVT, and PE incidences in the pembrolizumab and nivolumab anti-PD-1 recipients. There's no difference in myocardial infarction or myocarditis. We then conducted propensity score matching along the same demographic and comorbidity covariate classes that I mentioned earlier for the earlier comparisons, and found that significance was retained with an extra percentage of CVA outcome within 1 year of administration of ICI, and 1.5% more in DVT and PE, with low odds ratios that crossed the significance threshold. And this again was using these propensity score matched subgroupings among each therapeutic class of patients, while there was no difference in myocardial infarction or myocarditis. So as in most cases of cohort analysis using data aggregated from large repositories across many institutions using natural language programming, natural language processing, and other forms of EHR mining, the lack of individual patient level chart data does limit some of the inferences that we might take. Not being able to individually assess the presentation of every IR AE, the inability to assess, at the time, prior lines of therapy, though the database has sort of grown and swelled in sophistication since October of 23, it may have been. And now I would be capable of assessing prior lines of chemotherapy. The sample sizes that I looked at were similarly small in comparison to the overall size of the database. These have since grown as there is a sort of an increasing interest in this particular subdivision of cancer research. And in the larger second analysis comparing PD-1 and PD-L1 recipients, the lack of staging data is also a limitation. So to conclude, ICI recipients had greater 1-year incidences of venous thromboembolic disease and myocarditis, both at baseline and the gross analysis, and accounting for myriad demographic and comorbidity variables in a propensity score match model. And then using a larger set of non-M1 restricted lung cancer patients, PD-1 recipients had greater incidences of VTE and stroke than did anti-PD-L1 recipients. So this sort of at the bedside translates to the demand or the need to be wary of not only the pneumotoxicity, GI, hepatotoxicity, encephalitis, and other forms of toxicity that are sort of well known in checkpoint inhibitors, but also these cardiovascular complications that the literature suggests and supports appear in excess in ICI recipients, and the need for further work in tailoring potential prophylactic management strategies and sort of prospective trials to see whether this is something that does or does not benefit these patients. That's all I have for you. Thank you so much for giving me the opportunity to present it.
Great talk, Cosmo. I put a comment in the chat. If anyone does have a question at any point during the presentations, please place them in the chat. But I'll start off with a multi-part question for you, Cosmo. You mentioned in your limitation section that it sounds like the data set you used did not have individual level data, and it sounds like just group data. I wonder how, given that limitation, you and your co-authors dealt with, I guess, measuring the exposure and the outcome, ensuring that the exposure preceded the outcome. I think you had mentioned that you were looking at incidence of the cardiovascular outcomes within 1 year. Was that within 1 year of receipt of ICI?
Yes,
because I know that the exposure was also being determined receipt of ICI within a year as well, right? Just wanted to kind of clarify that. That's part one of my question. Then, if I may, part two would also be, given that this was a metastatic cohort for lung cancer, presumably the competing risk of death would also be of significant concern, and you'd be worried about you'd have to survive in order to receive ICI in the kind of experimental arm as opposed to in the control arm. Potentially maybe the reason why you're not seeing people get those outcomes is because they may have died. So I was just wondering how you accounted for competing risk of death.
Yes. So on the first prong of the question, I think that's a sort of a vital question, and my apologies for not giving this the clarificatory time it was due. The timelines we looked at were the outcome timeline we looked at was within 1 year of receipt of ICI versus 1 year of diagnosis of metastatic disease. So in the first analysis, we're looking at patients who have a diagnosis of metastatic lung cancer, on the one hand, receive an ICI, and then it is within 1 year of that we look at toxicity versus simply 1 year of those with metastatic lung cancer. And to address your and similarly in the second analysis, we're looking across the board toxicity within 1 year of ICI receipt. So wherever there is the incidence of an event in a patient who has received a checkpoint inhibitor, it is within 1 year of that. It is successive to the appearance of the checkpoint inhibitor in that patient's record. And to address your second question, it was, at least at the time, a sort of a systemic limitation within Trinetics, restricting outcomes to last contact, as it were, which could be death or simply disappearance from a particular healthcare system. So sort of events within that timeline that they were sort of known or generating information for a particular healthcare system, or for the many healthcare systems that were part of the federated network. So that is not something that I or rather that we addressed in this study, beyond ensuring that the patients belonged to the same stage, and we were comparing apples to apples. In prior iterations of this work, a significant limitation was not having the ability to specify that all the lung cancer patients were metastatic, because you could make the argument that the ICI recipients are those who have more advanced disease, for example, and thus are sicker from an oncological standpoint, and thus have that excess risk of VTE, which we could then address when the metastatic module came out. And now we could address that same thing using the restriction of last contact with the healthcare system, last contact with, or last point of generation of data for the aggregated data set. And that is a very good question. That was yet another limitation of using this sort of platform, though I must say they are advancing at a bit of a breakneck pace. So as time goes on, the analyses become larger and more sophisticated. But that is a very good question. Thank you.
A great job, Cosmo. Yeah, and I think this is very important, what you're trying to address. And I think obviously gives out maybe an incidence, but hard to sort of draw causation from this yet. But I think still a very good project. And thank you for presenting. We will move on unless I don't see any questions in the chat. And obviously, if you have any, we can take some later on as well. But we will move on to Dr. Peter Nauka, who comes to us from University of Pittsburgh, and he'll be presenting now. Peter, over to you.
Awesome. Thank you so much for the kind introduction. All right. Everyone able to see my screen all right?
Yes.
Perfect. All righty. So again, thank you, everyone. I'm really excited to be talking about procedural safety and diagnostic yield of various robotic-assisted bronchoscopy platforms. And I'm actually going to be showing some updated data from what I presented initially at ATS. So I'm kind of excited to be able to share this with you guys. So just a little bit about me, originally a native Californian, but moved to the East Coast, did my medical school training in internal medicine residency in New York before moving to Pittsburgh, where I'm a third-year fellow, currently on my research year. So some kind of important questions I hope to answer with today's talk is, one, does robotic-assisted bronchoscopy platform actually matter in influencing diagnostic yield? What do diagnostic yields look like in the era of the new 2024 chest ATS guidelines? How small a nodule we can actually biopsy, and what do we do with non-diagnostic cases? And I'll kind of go into these in a little bit more detail. So I think as everyone on the call is very familiar with, early detection of lung malignancy is paramount to effective treatment. And as we increasingly obtain more and more low-dose screening CTs, we're finding more nodules. However, peripheral nodules are difficult to sample for a variety of reasons. Traditionally, the conventional method has been using percutaneous CT-guided biopsies, which is well established, is kind of routinely done, but has a few complications. One is a high rate of pneumothorax. There's a risk of ipsilateral pleural seeding of the malignancy. And there's also lesions that are just anatomically impossible to reach with this kind of technique. I put higher yield here with the question mark because I think while conventionally we all kind of think of CT-guided biopsies as higher yield in robotic-assisted bronchoscopy, there really hasn't been any rigorous studies comparing similar nodules side to side. Robotic-assisted bronchoscopy, on the other side, is newer technology. The two main commercially available platforms are the Monarch and Ion. There's also the Galaxy by Noah Medical, which I think recently obtained FDA approval, but isn't really being commercially used yet. Robotic-assisted bronchs typically have a lower complication rate. We can target central and peripheral nodules. You can use it in conjunction with EVAs for staging. But the big issue is a variable diagnostic yield. And just reviewing the literature, yields have been reported from 40 to 90%, which is a very wide range. And this really just depends on what you consider as a positive yield and what kind of pathology qualifies as a positive yield. And so this really begs the question of how do we define that? And thankfully, this new consensus guideline kind of recommended a very conservative definition with kind of recommendations for how to standardize what a diagnostic yield means. And it stressed the importance of following non-diagnostic cases. So atypical cells, if you were not able to get any tissue in at least 12-month period. And then lastly, does the type of platform that you're using actually matter with diagnostic yield? So to address this kind of last question, we constructed a retrospective cohort study of adult patients undergoing robotic-assisted bronchoscopy at our institution. So we're pretty fortunate to have two hospitals, the VA, which has a Monarch platform, and the University of Pittsburgh Medical Center, which has an ION platform across the street from one another. And the same group of two IP-trained physicians and two thoracic surgeons do procedures at both sites. We were interested in comparing the yield between these two sites, between the Monarch and the ION, because this kind of offered a kind of natural experiment that even though that there is a little bit of difference between the population seen at the VA and our main site, and I'll go into that. And kind of given the concern for confounding between the different populations, we constructed a series of logistic regressions and did a few sensitivity analyses, which I will go into more detail. And we followed non-diagnostic cases for a 12-month period. So this is our consort diagram. We had about 217 patients in the study, 122 in the ION platform, 95 in the Monarch, and this is the breakdown of the pathology. And I will just say that in terms of how we determine what pathology result fit into which category, we had two of our co-authors, myself and another resident, kind of break down the pathology reports, and then any discrepancies between us, and we're blinded to one another, any discrepancies were adjudicated by one of the IP attendings. So this left us with a diagnostic yield of 56% in the ION group and 44% in the Monarch group. And non-diagnostic cases were considered any atypical cells, anything that was labeled by the pathologist as non-diagnostic or negative for malignancy, as well as any unsuccessful procedure, meaning tissue was not able to be obtained. So this is our table one, kind of comparing the two cohorts with one another. And not surprisingly, we found some differences between the two groups, which really reflects the population of the VA, meaning mainly higher predominance of male patients, more smokers, higher rates of emphysema, nodules that were typically more characterized with a bronchosine and spiculated nodule at the VA or the Monarch. I also highlighted PET imaging just because by protocol at the VA, almost everyone gets PET imaging regardless of their underlying risk for malignancy. It's just part of the pre-procedural protocol that is done. That was just another difference as well between the two populations. Some things I just wanted to highlight from table one is that the nodules that we're targeting were actually very small. About a fifth of them were sub-centimeter in size, and 3/4 were less than 2 centimeters. So, this is considerably smaller than prior reports, and I think just important to keep in mind as we're talking about the diagnostic yield. And in addition, about a third of cases occurred in the last 9 months of the 3-year study period, which just reflects, increasing utilization and adoption of this technology, which I think is also kind of reflected across the country as well. Complications were very unlikely in this study. So we only had 2 instances of pneumothorax, both at the VA and the Monarch system, and only 1 case of what I would consider significant bleeding requiring endobronchial blocker therapy, blood transfusion, and admission to the ICU. And that also occurred in the VA cohort. I will say that actually this pneumothorax and severe bleeding actually occurred in the same patient. It was just a very unfortunate case. So I think just really highlighting that complications are very unlikely and both platforms are very safe. Now, in terms of the question about whether the platform type influences diagnostic yield, our data would seem to suggest that the answer to this question is no. In our unadjusted model, parsimonious model, exploratory model, you can see that there's a little bit of trend towards favoring the ION, but it's not statistically significant. And in our parsimonious model, we included 3 different variables. In our exploratory model, we included 5 different variables to try to adjust for baseline differences in the populations. We also conducted a sensitivity analysis excluding the first 20 cases at each site, given that there'll be some amount of training and adjustment to the new systems, but this did not seem to change our underlying results. And we also did a sensitivity analysis including only patients with PET imaging available, and again, for the reasons that I kind of discussed previously. We also finally did a sensitivity analysis using nearest neighbor matching of baseline characteristics, and that actually was significant for the ion platform with an average treated effect of about 0.1 and a p-value of about 0.01 as well. But again, kind of barely meeting significance given our sample size. So in terms of the 12-month follow-up data, so this is a table of all our 109 non-diagnostic cases. These percentages here are out of 109. Some things that I just wanted to highlight is that and some patients could undergo repeat biopsy as well as surgical resection, so they could be double counted in this table. But about 15% underwent a second type of biopsy, while about a quarter underwent surgical resection were thought to be high risk enough to warrant surgery. An overwhelming of those in which tissue was obtained, adenocarcinoma was the most likely malignancy or finding. So I think this really reflects that we do need to carefully follow these patients because there could be a slow-growing adenocarcinoma that is not detected with the initial robotic-assisted bronchoscopy procedure. So some limitations that I've kind of already mentioned is it's a retrospective design. We couldn't fully report on biopsy methodology. We know that forceps versus needles does matter in terms of yield. We also didn't have cone beam CT or any kind of more advanced fluoroscopy at either of our sites, but that would likely improve diagnostic yield. Two different sites with two different populations raises the possibility of unmeasured confounding. And we can't exclude the possibility of a small difference between the two platforms, given the trend towards the ion platform. Although I think that if there is a difference, it's probably not clinically significant. So a few takeaways from this. Robotic-assisted bronchoscopy is a very safe procedure. We can biopsy very small nodules. And diagnostic yield was much lower. We got a composite yield of 56%, which I think reflects a couple things. One, real-world conditions, biopsying very small nodules, and the use of conservative 2024 ATS guidelines for a definition of diagnostic yield. As part of this work, I actually went back to some of the old papers and tried to recalculate diagnostic yield using kind of some off-the-wall numbers, the best I could. And I will say that probably using those definitions, you'll get a yield of about 50 to 60% in most of those papers. And while I think, the yield is disappointing for many people, I do think that this technology does open up the possibility of biopsying certain high-risk patients or high-risk nodules that are not amenable to percutaneous biopsy. And I would argue that there's still a patient population that this is probably the first-line technology. We just need to be mindful and careful in who we decide to send for robotic-assisted bronchoscopy. Next steps for me, collecting some 2-year follow-up data, try to publish this before I finish fellowship, and hopefully starting interventional pulmonary fellowship in July of 2025, currently in the process of applying. And then I want to thank everyone on the research team, particularly Roy Simon and Danny Dunlap, have been really supportive. And this is a picture of all the Pittsburgh fellows at ATS. So thank you very much, everyone, for your attention.
Awesome job, Peter. I think this was great. One, I mean, compared to, I guess, the ATS, I think you clearly have a lot of updated data, because I had questions that I'd planned to say, hey, you're saying, one was better than the other, but I do see some, patient differences. But a couple of questions that I had, and I don't know if you know this or not, but if we did do maybe not the conservative definition, but let's say, and not the liberal, but maybe a strict definition of diagnostic yield, would that change, your diagnostic yields comparing the two robotic systems? Let's say if you just took those that were inflammatory and watched out for a year, did that change the yield?
That's a good question. I did not do that. So kind of going back here, I did not do that. I was, just because the guidelines really kind of recommend not trying to change the denominator. So I actually purposely did not try to readjust or calculate a new diagnostic yield. So we actually submitted this initially after ATS for publication, and we got a lot of good reviewer feedback. In that iteration, I actually did present like an adjusted diagnostic yield, and I did that at ATS as well. And a lot of the reviewers kind of were, raised concerns about that. So I actually purposely didn't calculate that number.
Got it. And now, and also just briefly, do you think having an advanced imaging tool would have changed this diagnostic yield?
Yeah, I think it absolutely would have. I think, this is a big conversation at ATS. I think the consensus I was hearing is you probably will get about an extra 10% with cone beam, maybe a little bit higher with someone who's very experienced. But I don't think you're going to get 90, 100% that has like been previously reported. I just don't think that that's probably realistic with this particular definition of diagnostic yield.
No, I think makes sense. Yeah, and I think, what we were comparing to even CT guided biopsies, I'm not sure if they're accurate, right? Because they just biopsied something. We're not sure if that was cancer or not, but as long as they got a tissue, it was considered, diagnostic. So I think we weren't comparing apples to apples. But I think this was great. And I think, you should go ahead and sort of, get this out there as soon as you can.
I'll bring it up.
Yeah, great job, Peter. One other quick thing to kind of make note of, if I did the math correctly, it looks like your cancer prevalence in your entire cohort was around 43, 44%. Is that right?
Yeah, that sounds about right.
Yeah. So, that's another really important thing to kind of keep in mind, right? When you're talking about either diagnostic yield or diagnostic accuracy, which is more specific for just a binary outcome of, if you're looking at the outcome of cancer, for example, or, if you want to be more specific, non-small cell lung cancer. So just one thing to keep in mind is that, when you're comparing one study for diagnostic yield versus another, which it sounds like you're starting to do, kind of back of the napkin kind of comparisons to other published studies, the cancer prevalence makes a huge difference. So Neil Vachani published a simulation study, I believe it was in CHEST, that actually highlighted just how much of a difference that can make, right? Because if you have more cancer in your population you're studying, then you're much more likely to get a true positive, right? And so I think, not to be too discouraged, I guess, by the somewhat lower diagnostic yield that you're finding here, is that, your cancer prevalence is also a little bit lower than is what's reflected in other studies, which is typically generally around the 60% range. So that's a pretty big difference. So just something to keep in mind as you're kind of working on getting this to publication. And then so I've lost my train of thought there, but yeah, that's actually a really important thing to kind of keep in mind there.
And also, I think to note, you said 1/5 of the nodules were less than a centimeter. Now, the whole question would arise: why biopsy something less than a centimeter? And that's for a different day. But I think that's also something that you have to look into, I'm sure.
Yeah, and those things are exactly related. Actually, that was where I was going with that train of thought. Tejas, thanks for reminding me. It's that, like you said, Peter, people are getting more and more kind of aggressive with which nodules they're going to go after, and by doing so, you're necessarily going to be probably lowering your cancer prevalence in your ultimate, cohort when you finally get the, answers. So, really interesting work, and thanks for sharing it.
Thank you so much.
Yeah, absolutely. Last but not least, we have Vidhya Aroumougame from MUSC. Take it away, Vidhya.
All right, I had a difficulty unmuting myself. All right, can you see my initial slide?
Yes.
All right, great. Thank you for having me. So I am going to present today on the clinical evaluation of the standard convex EBIS probe versus a novel thin EBIS probe. So I'll refer to that as either the slim scope or thin scope throughout my presentation. So I have no disclosures. This study, however, did receive some funding support from Olympus. So as most of us are aware of, EBIS is the guideline recommendation for mediastinal staging in lung cancer. The really beautiful thing about this technology is that it allows for real-time visualization and biopsy of lesions. And it's very safe overall with a low risk of pneumothorax and other adverse events. However, it's limited by its diameter and angulation for most nodules. So it's a little bit difficult to reach nodules in the bilateral upper lobes and then further out in the lung, which I'll talk a little bit more about in the coming slides. So current technology for lung nodule biopsies don't give us that same real-time visualization and biopsy. And depending on what technology is being used, it can be time and resource intensive and potentially expose patients to more radiation than they may need. And so this is the device that we took. This is the device that we studied. So this is the thin EBIS scope. There are a few things that I'll point out to you between the two of them. On the image on the far left, you can see the standard EBIS scope on the left and then the thin scope on the right. It is thinner with technology similar to the standard EBIS scope at 5.9 millimeters compared to 6.9 millimeters in diameter. Its degree of articulation is a little bit more at 170 degrees compared to 160 degrees with the standard EBIS probe. The other thing is it doesn't have a balloon on the end, and the tip itself is actually a little bit smaller than the standard EBIS scope. So all of these things together allows for evaluation of airways and lesions not really achievable with the standard EBIS scope. And so some of the previous studies that have been done with this prototype have looked at how well it works in porcine lung and in cadavers. However, it hasn't been tested in humans yet. So we set out to do the first in-human study looking at feasibility and safety. And then from a secondary endpoint, we wanted to take a look at lesion visualization of the thin scope in comparison to the standard EBIS scope. So what we did was a single center prospective study consisting of about 51 patients with lesions located in the inner 2/3 of the lung that was determined by the bronchoscopist. And so initially we did mediastinal staging and then attempted visualization and biopsy with the standard EBIS scope. If the standard EBIS scope was not successful in visualizing or biopsying the nodule in question, then the thin EBIS scope was introduced for visualization and biopsy. So as I had mentioned, we had enrolled 51 patients. 7 patients were excluded from analysis as the lesions were visualized and biopsied with the standard scope. And with some of the lesions, it was unclear if they actually got a good sample. So the thin EBIS scope was used to attempt to sample those lesions. So that left us with 44 lesions. 7 of those were able to be visualized with the standard EBIS scope. However, because we were not able to biopsy them, we still used this thin scope to see if we could biopsy them. So of the 44 lesions that we were left with, the thin EBIS scope was able to visualize 36 of them and then biopsy 27 of those 36 lesions. So I have 2 images here. The image on the left is demonstrating the lesions that we were able to visualize with the thin EBIS scope. So as you can see in the upper lobes, which are a lot harder to reach with the standard EBIS scope, we were able to visualize many more lesions. And then if you actually look at the other lobes, we were also able to visualize many more lesions just throughout the lung. In the image on the right, you can see that the burgundy, and as I probably should have mentioned this for the image before, but the white boxes are those that we can visualize with the standard EBIS scope, and then the burgundy boxes are the ones that we were able to visualize with the thin EBIS scope. And then the black boxes were lesions that we weren't able to visualize with either. So we were able to visualize more lesions in what we thought was even further out into the lung. And so this is divided into thirds. So the middle third, inner third, and outer third. And you can see even kind of onto the border or into the outer third in the thin EBIS scope, we were able to visualize those lesions. So here are some example cases of lesions that we were able to visualize and biopsy with the thin EBIS scope. So a lesion pretty far up into the left upper lobe. And this one, we were pretty surprised that we could get to it, but it's this one right here. It has a pretty good bronchus sign. So that was impressive. So overall, looking at the lesion size that we were able to visualize and biopsy, we were able to get to levels that were
I think we may have lost Vidhya for a second here. Give her a second to see if she can rejoin. Technical difficulties today. Yep, we see you back, Vidhya. Looks like maybe just a little computer glitch there. I think you're muted, Vidhya.
And then I'm muted. Okay. All right.
And I believe the last slide that we saw was right after that box, that bar graph that you had.
All right. Are we back? Can you see that?
Yes, we can. Yep.
Perfect. Okay. So as I was saying, we were able to visualize 36 of those lesions with the thin EBIS scope, and then biopsy 27 of those. So overall, 23 were diagnostic and 4 were non-diagnostic. And there were 8 that we were not able to visualize with either device. And so we ended up using robotic bronchoscopy to get to some of those lesions. And so in terms of our limitation, our statistical analysis was limited due to sample size. At times, the slim scope did need revision. Kind of what happens when you use a prototype and you're evolving in terms of the device. There were some issues with the sheath being introduced, and there was at times damage to the scope. So that was able to be sent back to Olympus and fixed. And then we targeted lesions in the inner 2/3 of the lung, which was determined by the bronchoscopist. So in terms of the lesion localization, that was really largely determined by physician gestalt, as we lack criteria or anatomical landmarks defining the actual inner, middle, and outer third of the lung. And that sort of kind of leads into my next project, which I'll talk about in the next slide. But overall, we found that this device was safe. We were able to access lesions that we couldn't with the standard EBIS scope in all lobes, and most lesions that we thought were in the inner 2/3 of the lung. And this is really impactful in that it's able to extend the reach of EBIS technology. I think getting that real-time visualization and biopsy simultaneously is invaluable, and we can reach lesions further out into the lung. And so, as I had mentioned, next steps include a prospective multi-center trial that we are planning on starting in the spring. And then, as I had mentioned about lesion location, we're going to try to evaluate methods for defining lesion location to help guide selection of sampling and using this device. The two images here on the left show a software-assisted method to further kind of characterize the inner, middle, and outer third of the lung. And then, as you can see on the image on the right, there have been several proposed methods or strategies as to how to define inner, middle, and outer third. And at times they could be overlapping, such as if you have a lesion in the upper lobes, for certain definitions or proposed method, they could either be defined as the inner third of the lung or the outer third of the lung. So this plays a role in trial design in determining the potential for metastasis of lesions, and then also for diagnostic selection. And so these are my references. And then, of course, thank you to all of my mentors and everyone who helped make this project possible. And we are currently in the process of submitting this slim scope study and our findings to the Annals of ATS.
Great job, Vidhya. Absolutely great presentation. Really interesting work. Totally agree with you that the the classic definitions of thirds to determine location of nodules is problematic, to say the least. One possible suggestion, especially with regard to using a curvilinear probe device, for peripheral nodule evaluation, would be simply just to describe it by generation of airway. Since you're really trying to describe, how far out physically into generation of airway you're able to get for, the standard probe versus the thin scope, that just might make it a little bit perhaps a simpler way to maybe have readers understand just what the difference might be. I thought the cases you presented were really illustrative of some potential examples. But with that being said, I mean, I am struck that I think you mentioned 9 of the 36 cases you were able to visualize with the thin scope, but still were not able to biopsy, which is about a 75% success rate even with visualization. So, I think that's interesting, right? I'm assuming just due to the, anatomic location of the image relative to the, 45-degree angle of the needle coming out of the scope. But with that being said, I mean, with all the data that you have, I realize this is pilot data and, preliminary data. It sounds like you're waiting for, future, more mature data. If you were to start a brand new IP program, the, Dr. Aroumougame, School of Interventional Pulmonology, would you recommend getting a thin scope instead of a normal scope, in addition to a normal scope, in replacement of a robotic bronchoscopy platform? Or where do you see this technology fitting into the gamut of, all the different devices that we have? And I guess I'll leave it at that.
Yeah, great question. From your options, I would say I would recommend, and this is pilot data, as you had mentioned, and studies are still ongoing, but I think what was really impressive was its ability to reach the upper lobes in I would say a more efficient manner. So we still have to stage the mediastinum, and this hasn't been used or tested for that purpose yet. So I think it would be helpful to have this in addition to a standard EBIS scope. I did find that, in certain cases, we did have the robot ready to go in case we weren't able to access the lesion with the slim scope, and it just seemed very efficient in the ones that we could get to with the slim scope. And so we were able to not have to go through the time of setting up the robot, which I think from an efficiency standpoint, I think cuts out a lot of time and also, makes room for potentially, treating more patients if you're able to save that time. I do still think, though, that robotic bronchoscopy has a role depending on, certain lesion location. So I can't say that I would say that we don't need that at all. I think everything sort of has its role, but I think this is pretty cool technology. I still think it needs, a multi-center trial to see what other things it can do and what it's capable of.
Fantastic. Great answer. We have 2 more minutes. Tejas, any other questions or comments, or anyone else in the chat? Feel free to place any questions.
Yeah, I think, even I agree with what Vidhya said, and clearly trained from the same school of thought. I think having this, especially for those, more central lesions, definitely shortens the time. But then we've had these odd cases where we're like, oh, we don't get it, and then you start setting up. But I think those were few and far between. So I think that there is a definite place for this if we can sort of prove. And then obviously we haven't really, used this to stage the mediastinum. So that and again, I don't see why we couldn't use this. It's sort of very similar to the bigger scope, just smaller without a balloon. So I know there might be some issues with contact, especially in the mediastinal nodes, but I think it's still something worth looking into. But good study though.
Well, I think that concludes our webinar today. Thank you so much to all of our speakers for taking the time to share your really, really interesting work with all of us. And I know I certainly learned a lot, and I'm sure all of our viewers right now probably learned a lot, and certainly everyone who watches this recording. So thank you everyone for joining, and feel free to join us for our next webinar this Thursday at 3 p.m., where we're going to hear from some more abstract winners. And then we also have another webinar later this month on September 30th, where we're going to be talking about lung cancer screening in individuals who have never smoked. So hopefully some of you will be able to join us for that as well. Thank you so much, everyone, and have a great day.
Thank you, guys.
Thank you.
Bye-bye.